another A down there. It must be young kakluta. But yeah. Well, thank you again for the invitation, Fahim, because I was very reluctant about that. But with the time, we filled the hole, which I find a success. Maybe next time we start an hour later, and then we will start with a full hole. Well, paradigm shift. What do I mean? Well, I think that over the 30 years that I'm intensively doing hernia surgery, besides my visceral surgery, the understanding of the hernia disease has changed. We don't fix the holes. We try to treat or repair the whole region, the hole. So the hernia surgery by name went to herniology. For the more sophisticated, became parietology. And today we speak about abdominal core health. Well, it is true, but again, it's an American invention. It has its ground. It's not only about holes, but about stability, function, and quality of life. Well, it is a functional unit which is much more complex than expected. Well, the time when I did my first hernia in 1975, we just simply were not knowing quite well what we were doing, because the dysfunction of this unit causes various deficits. Not only poor posture, lordosis, chronic back pain, micturizaation problem, defecation problems, because the people cannot develop adequate pressure that they need, weakness, urinary stress, incontinence. So it's all about quality of life that people might define differently from their personal, individual point of view. Well, when I saw this diagram for the first time, I was just shocked, because I didn't know that the pectoral muscle would work in synergy with the interior oblique and with the adductors at the same time. And it shows only that it is not just the abdominal wall, as we know that with straight and lateral musculature, but all the others belong to it too. So if one does not function well, it needs the compensation. And the linea alba is the second stiff structure of the whole trunk, besides the spine. And mechanically seen, that's why that many midline hernias occur, because it's not elastic. And still it is the central tendon of the abdominal wall. Well, when we start with the normal abdominal wall, the first is the inter-rectus distance of more than 25 millimeters, although this is an artificial number. It could be 20, could be 30, just according to who's performing the surgery. Well, it could be caused postpartum, it could be inborn, it could be acquired by obesity. And it still can be the diastases recti with or without midline hernias for both sexes. Well, consequence of the diastasis is just that the oblique and transverse muscles are relaxed or not adequately preloaded. That means that the contraction of transversus abdominis is ineffective, resulting in the failure of stabilization of the trunk. And that's why we so many times speak about chronic back pain in context with the rectus diastasis. Well, repair of rectus diastasis aims to restitute the functionality, while the imbalance of the abdominal wall is repaired by easy plication of the rectus muscle, but that's not all. It has positive influence on back pains, it stabilizes the pelvis, it may even improve the urinary stress incontinence. I remember the first patient that wrote me 1 year after the repair that now she can jump trampoline with her kids and she's dry. So I started asking the women how continent they were after 2 or 3 kids. And astonishing, because normally you don't discuss these things, but that's what we have to learn in the meantime. The repair definitely improves the quality of life. Well, we started thinking about it more since the paper from 2015, Gernot Köhler, stating that the diastasis increases significantly the recurrence rate of the midline hernias, and that the absorbable suture material does increase the incidence of recurrence rate too. And this added actually the whole movement about rectus diastasis, because we started being concerned. What I did not say that the paper from Köhler was meaning actually in male, because male diastasis is not the same like the female diastasis. I will show you afterwards. Well, there are gender-specific differences. The postpartum, usually M2 to M4. The typical male, 65, not finding himself sexy anymore, has it between M1 and M3. Well, these are the males, and these are the women. The first difference is the age. This female group is just after 2 kids with 35, and the males after eating well, drinking well, after 30 years being obese with 60 or 65. Well, it differs from the female diastasis. The structural difference in collagen composition is something given. With the increase in age, the muscle atrophy causes the famous deformation of the male abdominal wall after 60 or 70. And of course, impaired body image, because our seniors today are aware of the fact that the body looks different with 60 than with 35. Well, the visceral obesity causes higher intra-abdominal pressure and lasts longer than the pregnancy. Pregnancy, maybe 6 months. Not that it is so short, but the first 3 months are not of importance. But there are gender-specific differences in the optimal surgical technique, because we definitely cannot use the same operation for the males like we do in females. The results of treatment of both sexes should be analyzed and evaluated separately. You should not make statistics with mixed population, because these two don't have really the same fate. Well, the changes of linea alba during pregnancy, well, it's a degradation of extracellular matrix, actually a biologic necessity. And all these hormonal situations, relaxin and all things I've heard for the first time maybe 8 years ago. I didn't know relaxin was so important. And it's only with women. And that leads, after propagation of the abdominal content, to the rectus diastasis. Well, we had to call it postpartum abdominal wall insufficiency, because we wanted to avoid the name of rectus diastasis, because rectus diastasis for ages was no indication for operation. So we had to change somehow the understanding of the insurers and all other colleagues. Well, it weakens the abdominal compression, the ventral stability, and reduce the reload. Actually, this is the major problem, because the young women have a weak back and come with chronic pain. And when you see that was the reason why we decided with the German Hernia Society to make this classification, just to get a kind of technical order into the differentiation of that, what we are doing and whether we are successful or not. Well, the European Hernia Society copied it now, just a year ago, did not add a word, but now it's called classifications for rectus diastasis. It does exist. While we, of course, address the localization, like here, M1, M3, M5, and the width until 3 centimeters, W1, W2, 3 to 5, and over 5. But when we talk to the other colleagues in the other parts of the world, we have from India, from South America, diastases over 10 centimeters. So you can imagine it's not the same surgery that you have to do if you want to repair or if you have to repair, not you want to repair. Well, this is the M1 to M5, different segments of the abdominal wall. Sorry for the propedeutic information. The indication to surgery is actually after failure of targeted conservative measures. Of course, severity of the rectus diastasis and symptomatic. Associated midline hernias, especially in men, when you realize that you make a simple repair of a 3 centimeter hernia that has such a high recurrence rate, no matter where you put your mesh, if it is on the basis of rectus diastasis of 8 centimeters. It's always the proximal margin where the recurrences appear. Of course, skin laxity is an important fact, whether you do it together with the plastic surgeon or not. Does it need a classical abdominoplasty? But again, this is, in my eyes, the only true indication, grade 2, rectus diastasis between 3 to 5 centimeters with very little skin excess, because the operation that we do does not change the skin excess. When they need removal of skin, so it should be plastic surgeon who should do that. Well, there were several informations in the literature about gaining, improves the abdominal wall's muscle strength. Most of the papers came from Scandinavia. This is one from Anders Olsen, where 60 women were controlled 1 year after stabilization of the abdominal wall with different techniques. 98% reported improved quality of life. And I think this is what counts. They were doing well, 3/4 were doing harder and endured longer. Well, back pain is an issue being addressed in several papers, like Beito Luca from Spain found significant difference before and after the operation. All the authors that you see here, you've been laid them, all found significant improvement of the stabilization of the drug. Well, here, nice demonstration from Alessandro Carrara. Well, you see the dark green bars are preoperative. The second row is after 1 month, and the third row after 6 to 8 months. You see that all moves to the left of the graph, improvement of stability, and it of course does not change 2 weeks after the operation. You have to stabilize your muscles first, and then you can count on it. Well, posture, very often indication for the orthopedic surgeons who ask us to stabilize the anterior abdominal wall. When you see somebody with 35, like the lady up there after 3 kids, it's, she's suffering, actually. This, everybody asks, well, are you allowed to show that? Well, the patient asked me for that, to show that. She's one sport climber that feels the best in the upmost corner there and hangs there. Needs incredible strength of the abdominal wall muscles. But this is what it does. It changes posture, changes the axis. Again, urinary stress incontinence. This paper is on 110 patients, so this is not just a report of 3 or 5. And I think we have to get used to that. I find it, well, I know Alessandro personally, and he is a great surgeon, and that's why I love to show his material. Again, after 8 months, well, now comes something I call busy slide. Don't be afraid of that. It's preoperative are the blue bars, the yellow bars. The colors are not really very happy. Well, the second bar is a short time after the operation. The red bars are after 1 year, and the last bars, which is in my computer violet, are the normative values. So you really can restitute the condition of the abdominal wall if the indication was correct. There are different techniques. Well, I don't know if we have time for that all, but we differentiate the hybrid techniques, which are making skin incisions there where the mesh comes. That means increased risk of infection. LR and MILR, I will show it in the graph. Well, LR uses the part of anterior rectus sheet, flips it medially, sutures it together, and covers the defect with mesh. It's not an onlay which just covering the fascial defect which was used to reinforce the suture line. Well, there are other techniques. You can use Icon Plus, you can use Lira, which is the Spanish technique that does the same but with a posterior rectus sheet, makes the flap, brings it medially, suture it, and puts the mesh intraperitoneal on it. It's actually intraperitoneal only. There are multiple techniques. Well, we start with the subcutaneous ones, Rectus, Cola, Tesla, Fessa, something very, very, very similar. Subcutaneous retromuscular, Tessa, transabdominal, or preperitoneal, ventral tap or T from China, or retromuscular, TARM from India. So you see that actually the whole world is trying to improve something in younger people, avoiding the intraperitoneal position of mesh. If you can do that, it's definitely a positive thing, because there is nothing easier than to put just another carpet on the wall and fix it with 80 tags. It's not only not cheap, but it hurts. Well, there are, as I said, there are many techniques, but actually what we see that there is a difference in the behavior between males and females. Well, seroma incidence in men is much higher than in females. This paper is from Italy. There can be another paper from Spain where it says, again, between 3% and 36% of diastasis recurrence. That means that was not the good indication. And that's why I say you should not operate men with the same technique as you do for women. It's a different group. Fessa technique, something not really new, but again, if you then think it's to the end, it's a endoscopic LR. Again, you take the anterior rectus sheet, flip it medially, put a mesh on it, and do it everything endoscopically from the suprapubic incision. That's maybe more sympathetic for the young female patients. Well, I don't want to repeat that, but actually it's a clean surgery. It looks much better when it's clean. You know what you do much better when it's clean. So actually, why not to keep it clean? I fix my meshes that support the suture line. Is just 6 centimeters wide, and I fix it with cyanoacrylate glue. This is probably the least important fact at all. A technique that is similar to Repa, Scola, these are actually home production. Suturing, actually medialization of the muscles and reinforcing the suture line with a prosthetic material. We still don't know if it is necessary, although we know that the abdominoplasties by plastic surgeons have more recurrences if they don't use any mesh reinforcements. Well, there are stapled repairs if you just want to make it complete. I see some people from Trento here, so it's a Trento hernia technique. Well, interesting. Periumbilical incision, opening of the muscle layers, well actually the anterior rectus sheet, inserting the linear stapler, firing the first, firing the second, getting the preperitoneal space nicely done, but it's the question of the tension. These staple lines were made for tension-free intestinal anastomosis and not for closing posterior rectus sheet together with peritoneum under tension. And all of them, all the authors, and I know that most of them personally, had experienced a rupture in some cases, postoperatively, caused inner hernia with obstruction of the small bowel. So that's, I don't know if really it will stay, but all these have, after half a year, much improved abdominal wall functionality, and this is something why we are talking about it. So let me conclude. Rectus diastasis became a hot topic. The reconstruction of linea alba may improve functional deficits. Rectus diastasis repair improves the quality of life. Male and female rectus diastasis are different. Rectus diastasis with midline hernia requires special attention. Too many different repair techniques. Maybe we have to try to find out what is so good about the one or the other, while the correct indication, as anything in surgery, is the key. And again, welcome.